everyone, and welcome back to the afternoon session. It gives me great pleasure to introduce our next panel, Next Generation Hospitalisation, the Patient Care Experience of the Future. Personally, I can't wait to hear about this panel. I think it's going to be incredibly interesting. As always, please don't forget to post your questions in the chat Q&A box. We'll get to them as quickly as we can, and obviously try and get through as many of them as possible. So without further ado from myself, I'd like to hand you over to our moderator for this particular panel, Sarah Elizabeth Richards. She's the health and science journalist for Wired, amongst other things. So Sarah, over to you.
Hi, thank you so much. Thank you so much for joining us. I am a health and science journalist, and I am especially interested in how medical and technical breakthroughs impact patients. So I'm thrilled to be moderating this panel. We have an esteemed lineup. We have Karen Murphy, who's the Chief Innovation Officer of Geisinger Health System based in the US state of Pennsylvania. We have Adam Landman, Chief Information and Digital Officer of Brigham and Women's Hospital in Boston, and Neil Sabir, Chief Research Information Officer at the Great Ormond Street Hospital in London. Welcome. So this couldn't be a better time to dive into this issue. It's been a hot topic for years, and yet now we're smack in the middle of the biggest social experiment we ever could have imagined. So, of course, we have to talk about this. What role has COVID played in ushering in changes that have affected the patient experience? What are some of the positive things that you think are worthwhile and will endure?
I can help start us off here. I would say COVID has really provided, COVID has been a difficult time for many. And first, I want to thank all the healthcare workers and essential workers that have, given so much of their time and energy and to care for those in need and to provide essential services. But there's been some silver linings of COVID, and digitization in healthcare is clearly one of them. And what I would say was missing before COVID is sort of that burning platform, right? Many of us in our chief roles have been advocates for digital, but honestly, COVID has really been what's tipped us over the edge. It's provided the reason for us to really go digital. And if there was any question of whether healthcare could be performed digitally, I think that question's been answered now with COVID. And as one quick example, and I think this is common, across the world, is that we saw an immediate shift away from in-person visits to virtual care. And I think we saw staggering numbers and examples of this in my organization in Boston. At the peak of COVID, we were seeing 70,000 virtual visits a month. And before COVID, we probably only had like 1,000 virtual visits a month. So these were huge transformations that I think are going to persist as we go forward.
I think so too. All the studies show so far is people like it. It's this whole new way of doing, medicine. Any other examples people want to offer?
I guess from our perspective, I totally agree in that it's given us the push we needed, but to some extent, I have to say I've been a little bit sort of frustrated because we've gone to, by and large, what we're doing now. We've gone to video consults or telephone consults, but actually when you start talking to some of my colleagues about why are you not using Bluetooth enabled stethoscopes, why are you not doing other things, why are we not pushing more, there's still a little bit of reticence. So I think it's great that COVID has kind of pushed us over the first hump, but what we've got to do now is keep a bit of momentum for that. And it's interesting that I'm sure this is happening in lots of places, but for example, in London, there was a big study going on about home monitoring with pulse oximeters just being given out to various patients. And the idea is great, but it is also really highlighted some of the issues with how do you get that data now into the appropriate systems and how do you share that? And some of these things that people think are quite simple in terms of the infrastructure problems have also been highlighted. And we've certainly seen that just around trying to get data from who has COVID, for example, across hospitals in the UK, depending on how the coding systems are done and all sorts of other things. So it'd be interesting to hear from others' views as to whether that's a universal thing. So I think it's been great to give us a kick, but I'm not sure we're being brave enough on the back of it to really take things a bit further.
Yeah,
So
and I
it's a
think I would piggyback onto that I think that's about a leadership role. So I think leadership going forward post-pandemic is about saying, you know, a year ago, we brought the health system to its knees. We stopped doing everything. We innovated in hours, not days, not weeks, not months.
Good.
And that we did find solutions that heretofore, there was just a list of reasons why we couldn't do it. So we extended that innovation time period or piloted things for years. I think COVID has proven to us that we're tremendously flexible. And I think we have to keep that in mind. We're tremendously resilient. So if we try something and it doesn't work, we can come back from it. And I think finally, though, Neil, to your point, and even piggybacking on of Adam, I think all of these new tools that we brought into our toolbox post-pandemic, with the help of God, that'll be months, not years away, but post-pandemic, we really have to start looking at evidence and say, where do these make sense? So just because we can monitor everyone at home doesn't mean we should. Just because we can do a virtual visit doesn't mean we should. So we're really starting to look at the point of how do we form evidence to say this is the right thing to do because it's a better outcome and it lowers the total cost of care. So I think they're kind of the messages that we're trying to inculcate here at Geisinger, to start thinking about tomorrow and thinking about how do we develop the evidence.
Neil, anything that you think has gone too far or things that we need to rethink?
I'm not sure. So I'd agree. I think we have no idea what is the sweet spot, what is the optimum for all of these things. But I think one of the other things that is relevant, regardless of what your payer system is, that this has also shown up for us, is more generally, if you can stop patients coming to hospital, it's better for the patients, it's better for society. But the question then is, who gets the benefit from the money that's saved from that? And even in systems like the NHS system, we as a tertiary hospital only get paid if the patient comes to us. So if we keep them at home, it's great for the patient, it's great for the NHS, it's great for the country, but actually it's quite bad for the hospital. Now that's not so bad if you've got a managed care system and one organization manages everything, but when you're doing national things, and I'd be interested to hear the views of Adam and Karen on this, because I think this is a major thing that needs to be sorted out around, and I know for us it's slightly different, but I guess from my US colleagues, it's around the reimbursement for the doctors as to who's getting paid for these things and do you get the same, etc. And until that gets solved, I predict this will be a thorny issue for how these things will be rolled out.
I feel like the cat is almost out of the bag. Now every time my doctor says, "Oh, sorry, you have to come in for that," I know I really don't. So yeah, how are we going to reconcile that?
Well, but we're in an interesting time, right? In the U.S., in some states, and certainly in the state of Massachusetts, they've extended reimbursement parity for virtual care. They enacted that during the state of emergency, and now it's continued. So I think that's important, and it gives us some time. And I think Karen was hitting on this. We've got to form the evidence base, right? What is the appropriate, what care should be delivered and is appropriate to be delivered virtually? And then what's the appropriate reimbursement for that so that we can align all the incentives? And I think there's a significant amount of work to be done there.
Karen,
to piggyback on that. So the US, and I know across the globe, we're trying to move to value payment as opposed to heads in the beds, and the number of services clearly don't work. So if you look back on the pandemic last March, we all did the right thing. We shut down our elective services. We closed our clinics. We deployed people to take care of sick COVID patients, and literally ended up in a financial disaster. Here at Geisinger, just the first wave, we even haven't totaled the second wave, but the first wave, we're looking at about $500 million in lost revenue, which the only way you make that up is try to repeat those services. And it's like a hamster on a wheel. we have to get to the point where if we're going to, and because if we don't, let me just say, if we don't get to the point where we're reimbursing on value and it's a win-win for both the health system and the payer, we're going to go back to the way we were before. And it's going to be inappropriate utilization, get the face-to-face visits, don't get the patient in the hospital, where our values are totally opposite that. We want to bring care into the home. We want to leverage digital technology and monitoring patients in the home. We want to decant the emergency room. But to your point, Neil, you can't do that at the peril of the business model, because we won't be able to take care of the patients. There are always going to be a set of patients that have to be in the hospital and that require critical care or require surgery. And we have to get to a value-based payment model that allows us to do the right thing at the right time in the right setting, and it offers a sustainable business model. And I think the pandemic has clearly demonstrated that. We've given a lot of lip service in the United States to that over the last 10 years, but I think the advocacy has to accelerate. But we have to be able to show evidence to the policymakers. I mean, we can't just raise our hand and say we want more, because the total cost of care is out of control. We have to be able to demonstrate the evidence and then do the right thing for the patient.
Excellent. Adam, I'd love to get your thoughts on this one, of things that we thought about in the pre-COVID days. What are the things that impress patients the most in the hospital room of the future? And I'll share a couple examples from my family. My mom was in the hospital with cancer last year, and she loved being able to order food on a tablet. It gave her a sense of control to be able to order her own Diet Coke and cheeseburger during a time when, of course, she had very little control. And my aunt recently had an emergency gallbladder surgery, and she texted me about some new contraption, that there was a shower cap that you heat up in the microwave that you put on her head to massage it. And it was fascinating of all the things going on. Like, this is the thing she's texting me about, but it made her feel really cared for. So I would just love to, get a thought on what are the things that really hit home for patients? What are some of the feedback you're getting?
So one of the, thanks, Sarah. And I think there's a lot of opportunity. I'd love to learn more about the shower cap. I'm not familiar with that innovation, but you piqued my interest on that. But I think one of the things we've learned during COVID is we can actually do some simple things. Many hospitals across the world actually just put tablets inside patient rooms. And those tablets served a number of purposes. One is it can provide patient entertainment. And many patients may be hospitalized, may have forgotten their phones, may have forgotten their devices, and visitor policies are restricted during COVID, so they have minimal contact. And so having a device at the bedside enables them to have some entertainment, but also stay in touch with their friends and family. Those same tablets, and the reason I think many hospitals put those tablets in during COVID was because we wanted to try to do a couple of things. One is preserve PPE, personal protective equipment, masks and gowns, when those supplies were limited. And we wanted to reduce the number of interactions of our staff with patients that had COVID as much as possible. And so by putting a tablet in the room and having a device outside the room, you could actually have a virtual intercom system or a conversation. And that technology, we saw that deployed in many forms across, again, hospitals across the country and the world, and was extraordinarily valuable, to the point where our providers didn't want to give it up. And in fact, we're continuing to use it even with patients without COVID. And so I think we're going to see that simple technology, even just a tablet, and it can be bring your own device if someone has one, or it could be if you don't have one, that the institution provides it, but that provides entertainment, communication, and also access to patient records at the bedside. There's the ability to check your electronic health records, so you could see your lab results or pending image, or when your imaging test is going to be done, and the results of it when it's back. So those are some of the things that we're seeing immediately that are starting to take hold now, and we're getting patients like it. We're increasingly, the clinical staff, the nurses, and the doctors are also really finding value in these products.
Awesome. Anyone else? Any other examples of things that patients really appreciate?
I think communication. I think that, under ordinary circumstances, the best health systems in the world are very difficult to navigate. I think COVID allowed us to be very strategically focused because all we were doing was COVID. So we had very clean lines of communications for patients. They knew where to go to get information, whether it be their appointment, whether it be learn more about COVID disease. And I think it really resonated that patients really expressed gratitude during that time, that they knew they had somewhere to turn to and they could get their questions answered. I think going back to the talks of digital, I think that's where we have to focus on improving those lines of communication for patients and really leveraging digital to transform the journey so that it isn't.
We've actually got a follow-up question on that from the audience, but I wanted to, Neil, see if you had anything to add about that first.
Yeah, I mean, I think it's quite interesting that from our perspective, we're a specialist children's hospital. So maybe our perspective is slightly different. But one of the things that's made the biggest difference was so simple. And that, from my perspective as the CRIO, is a little bit frustrating because we're doing all these things with trying to do things with robots and other stuff. And actually something much more simple turned out to be the more thing. And it was actually something we brought in about 18 months ago called Essence, which is for every child who comes in, we now collect their favorite toy, their favorite TV program and information about them so that whenever they come in, if they like Minecraft, we have Minecraft running on the monitor when they come in, or if they have a particular football team, we try and put that on the screen. And actually that has made a dramatic difference because patients already don't like coming to hospital and they're even more scared of coming during COVID. So just the simple thing of the first interaction you might have with a child and a family is, oh, we hear you like Chelsea. I'm a Manchester United supporter. And then suddenly the engagement is really different. Now that sounds like a really simple thing, but it's using technology to make that human connection more. And in fact, I would say of all of the sort of simple things we've done, that's probably the one that is now being used most widely and has probably made the most difference to more people, just because it breaks that barrier down. And even more when people are very scared. Families are scared of coming to hospital with COVID. They don't want to come into hospital. So actually anything you can do to make that experience better. But as I say, the sort of more sexy, techie things are the things that we tend to get excited about, but actually are not necessarily the ones that make the difference.
I love that. That's a great example. All right. So our question is, what do you see as the sweet spot for balance between digital and in-person patient care in the future?
I can try to take an initial stab at that. I'll actually just give a clinical example. So I'm an emergency physician and I do virtual urgent care a couple of times a month. And one might think calling to virtual urgent care for something like ear pain would be really a good use of virtual urgent care. Well, it turns out there's a major problem with this, which is you can see the outside of the ear, but I can't see the tympanic membrane or the ear canal in a virtual visit. So until Neil and his team come up with some sensors and devices that can be deployed in advance to everyone's home, we're going to be really limited. And so I actually think we're learning this. The good news is we've collected a lot of data during COVID. We now are starting to learn what you can do virtually and what you can't do virtually. And when I say can and can't, what's clinically appropriate to be doing virtually versus not. And so we can start to be putting together, guidance and guidelines for what types of patients, what types of chief complaints can be evaluated virtually, and which need to be in person, and which might there be some type of combination where maybe you have an initial virtual evaluation and maybe you get triaged to in person. But I think that's the work that needs to be done. And to give some other examples, we're seeing specialties like psychiatry that after the initial assessment is done, they can do a very large percentage of their care virtually, and they're able to continue to provide very high levels of quality of care. And so I think we have this work to do, this analysis of understanding what's appropriate to be done, monitoring quality, and then triaging and directing patients to the most appropriate level of care.
Good example.
I think the sweet spot is really going to be when we hit a place that our patients are actually telling us that whatever digital application that we've employed is better than their previous experience without digital. That to me is the sweet spot. It's not going to be everything. I mean, we're not, we're a human touch relationship. And we're humanistic in our approach to patients, but I think we need to continually evaluate with the patient and engage our patients in telling us where that sweet spot is.
Good point. Neil, you want to add to that?
Yeah, I totally agree with all the points, but with Adam's point particularly around, we are now starting to get evidence around what we could, for different conditions. But this brings up another frustration, because I bet you that our hospital is doing it, and Adam's hospital is doing it, and Karen's hospital is doing it, and we're not sharing it in a way that we're learning from everyone else, because almost every healthcare institution is doing this and has tried slightly different things and has learned different subtleties. And there is a massive amount to be gained now if we're going to leverage what we've learned from COVID around virtual visits, of having that information shared, because there may well be things and types of patients to save us doing it. We can learn from what other institutions have done, and also different patient groups, because what may work for an adult may not work for a child, or it may work for a child over 10 but not younger children, or not elderly patients, and all of those kind of subtle things. And again, apart from the traditional route of you're going to try and write a peer review paper, which everyone is now trying to do about, we did virtual visits, aren't we clever? It's actually quite hard to share that information. And again, I feel this is a slight missed opportunity perhaps for medicine moving forward, and actually not being quite so precious, and actually just learning from what everyone else is doing.
Nice. Actually, this is a good opportunity. I know you had teed up some other issues, like what are how do we overcome some of the challenges of putting reforms forward, like infrastructure, data management, training staff. Do you want to jump into that one?
Well, maybe I'll just start off and then because I'm sure there'll be sort of lots of comments on this. One of the things that we've certainly noticed is that trying to discuss in the previous few years at high level, either with boards or with government or regions, about the need for infrastructure and the need for standards and interoperability, etc., is quite a hard sell, to be honest. People were not particularly interested. You were seen as the slight nerdy data guy. Whereas actually now, the whole COVID situation, I think, has made governments realize that flowing of data in a way that is interoperable and standardized would be helpful for all sorts of things. And they're starting to realize that health data does not generally flow that well and is quite hard, because different institutions may code things differently, etc. And certainly in the UK, that emphasis on infrastructure and data and standardizations and the back end, if you like, has massively gone up the agenda. It remains to be seen whether it will deliver, but it's certainly gone up the agenda. And I think that actually can only be good, not just for the healthcare institutions, but for patients as well. Because if we can start to get that right for what we do, it also means that there's much more emphasis then on patient-facing apps and all sorts of other things, home monitoring devices, the standards, the infrastructure, the interoperability part is actually put front and center, which it traditionally hasn't been. So I think that one of the, in a way, the biggest spin-offs of the whole COVID situation for healthcare will be a big push forward in actually trying to understand data flow in a much better way.
Nice.
Just maybe building on what Neil said, and also acknowledging that it's hard to get investment for infrastructure. we were fortunate in my health system that we did get a pretty sizable capital investment and other investments into digital infrastructure, and very fortunate to have visionary leaders that supported that. But what I would also say is it exquisitely paid off during COVID. We were just in the process of investing resources in cloud infrastructure for data, as well as data analytics resources, and we leveraged all of those folks to be able to provide updated dashboards for our hospital capacity, for our testing infrastructure, for vaccination. And if we did not have that, we would not be able to respond in the way that we're responding now. So I feel fortunate. We were lucky, very fortunate in the beginning to have had that support, but I think now we have sort of indelibly showed the value of that investment, which is very hard to just get infrastructure. You have to balance an ask for infrastructure investment with a use case and application. And again, this is where I say COVID sort of came at the right time. It showcased these investments we were making. And now hopefully we're going to be able to leverage that and say, please keep investing, because now we need to do this for all aspects of care, not just for COVID related. So thanks, Neil.
And Karen, this is a good opportunity to jump in on this question because I wanted to get your perspective. How do we start to think about this in terms of different areas, maybe with fewer resources?
So I think the reality of digital is that it will require significant resources. And if you try to do a Band-Aid approach, you're not going to be very successful. So I think the point about digital is really, it has to be a strategy. And the strategy starts with laying the foundation of the house, which is the infrastructure, the interoperability, the data integrity. Because if you have a board that thinks that they just want to have an app out there, and then we want to have another app out there, or we can go and take a little piece of data, that is not the transformation that Neil and Adam and I are talking about. We're talking about transforming the delivery of healthcare. And in order to do that, we have to do it strategically, and it has to be funded. And the level of funding will really determine how far you can go to transform the patient experience, healthcare delivery, and the total cost of care.
Okay.
And there's almost a kind of joke at the moment in the UK of so the Prime Minister and the Chief Medical Officer do daily or weekly, depending on the rate, presentations. And you would never have seen kind of PowerPoint presentations with graphs and 95% confidence intervals at peak time on the TV. And the public and in the newspapers are talking about the R number, and the thing of data and seeing dashboards, like Adam was saying, is something that we'd never have got people to do even a year and a half ago. And now people are starting to see the value. And I think also, as Adam says, it really has highlighted the massive difference between organizations that were already starting to do this, so could quickly provide their data, have their dashboards, give these things, and organizations that were lagging. So I think it's really going to sort of highlight the difference and actually the value of all that investment.
I would just amplifying that and maybe thinking a little non-COVID right now. I also think that health systems have to invest in this space. From my perspective, it's an imperative for life sustainment. I think we're in a real period of disruption, right? What we also saw during COVID is we saw digital health companies receiving record levels of venture funding, right? And many of those digital health companies have models that disaggregate healthcare systems. So we either, meaning there might be a diabetes digital health startup that they might work directly with patients and provide diabetes care and monitoring and medication titration. And there may not be a need for the patient to come into a health system anymore. And so I really think healthcare systems have to really think carefully about how are we going to play? What are our roles as the world changes? And so that's the other reason why these infrastructure and also program, and as Karen is saying, true transformation of health systems have to happen. I think it's necessary for survival going forward.
Okay. What are some of the arguments that resonate with funders? Like, what are the things that really get them excited or get them on board?
Do you mean like VC funders or?
Yeah.
I mean, it's interesting. The one thing I remember,
Or payers, I mean, just I guess I'm just trying to cover the whole, like what are the financial arguments that resonate?
I'll share one thing on the VC side, which sort of surprised me, and this was earlier, but at least in healthcare, digital health has taken some time to take hold and get traction. And one metric they look at is sheerly adoption. Like, are people actually using the programs? Because if someone uses an app once, it's not that interesting. But if you're starting to use that app every day or that program, that digital program every day, or it's starting to really take hold, that may signal a true transformation. So just looking at usage, and then clearly looking at the return on investment. And I think clearly VC firms, as well as internal organizations funding programs, as well as payers, they really do want to see the value. Are we replacing high cost care with digital programs that may be more cost efficient and that still provide the same quality of experience?
Anyone else have anything to add on this?
I think we've probably got a slightly different push in that, obviously the payer system is different in the UK, and therefore the main emphasis around getting people to invest is things that help society rather than necessarily things that might help an individual patient. So if you can do something that makes the healthcare system more efficient and more effective, that's the kind of thing. And I think one of the things that's also massively been amplified in the recent times is the fact that healthcare data is important, but actually a lot of the decisions you need to make about healthcare, you need data that traditionally doesn't come from the healthcare system. Now, whether that's social care or whether it's about schooling or whether it's about income or whether it's about all these other things, how you're going to roll out a vaccination program, how you're going to get hard to reach groups. And this is definitely a thing that I think has been pushed up the agenda, but is actually quite difficult to do, or certainly for us at the moment in the UK is quite difficult to do, because each of these are seen as separate silos, and it's actually really hard. It's hard to link someone's data across different types of data sets just because of the governance that we have. But I think that the COVID situation has really shown people that there is value in doing that. So for us, it's around how you can do things that will allow you to make the whole system function a bit better, perhaps is more than when you're getting individual patients who are paying.
That makes sense. What would you like to see next? What deserves priority?
I would say, to start with, priority is really advancing value-based payment, because in order for us to achieve true transformation, whether that be digitally, new models of care, we have to move to value. I think we've been tremendously held back in what we are capable of doing. It took a pandemic for us to begin to transform in days, hours, and weeks, not years, months, decades. So I think the priorities would be definitely to keep the silver linings of what we've experienced during COVID, is to transform health payment. And we have to, globally, we've got to lower the total cost of care. And so we need to be able to have the right incentives to be able to lower the total cost of care. I also think that sustainable business model will let us continue to transform, leveraging digital technology and leveraging not only, I don't want to just hone in on the digital piece. It's really the transformation of the care that's supported by digital. So we're thinking about changing care, delivering new care models that are really supported by digital tools. And we need sustainable business models to be able to achieve that. So I think that's priority. And then I would list just the last one is the industry's ability to hold on to strategic focus. So why we have been so successful during COVID is that we had a clear mission. It was to protect our patients, our communities, our employees. In the pandemic, we were all going in the same direction. And I think we, as an industry, have been have had a very scattered approach as to what ways we need to focus on to be transformative. So I think this lesson that has come out of the pandemic is we need clear strategic focus, that everyone understands what the mission is, where we're headed, and how we're going to get there.
Can I just build on the excellent points that Karen made? My concern is we've had phenomenal success, particularly around digital solutions. But one thing that's still concerning to me are the equity issues, that there are some patients and family members that simply don't have access to this. And, I'm worried that we're creating sort of a two-tiered system here, and really need to think carefully about it. I don't have the answers. We really struggle as we are making a conscientious effort every time we make a digital program to think about how do we ensure that the services are offered to everyone. And increasingly, I'm interested in, digital skills are not just required for healthcare or becoming required for healthcare, but they're becoming, if we think about the way our lives have changed, they're being required for everything from going to school to, doing shopping. I mean, everything has a digital element. And so I also wonder whether there are opportunities for us to work as a community, as a society, to help ensure digital literacy and also digital product availability, both phones, tablets, computers, and internet connectivity for everyone, so that they can get their healthcare digitally, but also carry out all other essential tasks. So I'm concerned about it because I'm worried that we're only going to get more and more digital over time as we get more and more sophisticated, and we need to make sure we are providing that same level of service to and availability and accessibility to all of our patients.
Yeah, good point. Neil, what would you like to see next?
I think, again, slightly frustratingly, in that, because my own interest is around things like AI and machine learning, etc. They're not the things I'd like to see next. Actually, the things I'd like to see next are the much more simple things, like a bit like Karen and Adam have touched on. And the one thing that I'd really like to make sure we keep is the ability to question what we do and make a decision and act on it quite quickly, because that's been almost the biggest thing. If I had gone to the trust 2 years ago and said, how about let's do 80% of this clinic virtually, people would have laughed. I mean, it wouldn't even have been a thing. And actually what's happened through this process is someone's gone, well, hold on, do we need to see this patient? Do we need to do this? Do we need to do this? And simply, these are not rocket science questions. We could have asked these questions 2 or 3 years ago, but actually the fact that we did is a thing that I would really like to see keeping, to say, can we question everything about the way we are providing care in given scenarios? And it may well be that the way we're doing it is optimal, but it's likely that it's not. And it's those really simple things that make a difference to lots of people. So a bit like Adam mentioned, actually just making sure that everyone can have access to the internet or log on or do a simple thing is probably much more value for society than having some amazing machine learning thing that works in a tiny proportion of cases.
Nice. And these are the big, lofty, future-esque questions I like to say for the end of a panel. How do you see the role of the hospital changing for patients? Will we think of it differently?
So Sarah, maybe I would start by saying we're always going to need hospitals, right? So, I mean, I think there are certain patients that require hospital level care. And increasingly that's going to be the very sick patients that are in our intensive care units, right? That require sophisticated technologies, very close monitoring, and access to many of the ancillary services the hospital offers. But increasingly, I think we're going to see patients cared for in other settings instead of the hospital. And so we're already starting to see the rise of the home hospital programs. So a patient may come into an emergency department, be evaluated, and that patient might usually be admitted to the hospital, but now many organizations are starting home hospital programs where the patient can be actually sent home, under the care of this home hospital program, where they get physician, nursing level care. They have access to laboratories and imaging. And some of the initial studies that have been done on this are very promising. They show that patients like it, that they have lower total costs of care, they have lower utilization of imaging and laboratories, faster mobilization. So really promising results. So I think overall we're going to see a shift away from hospital services for a certain segment of population, and then of course continue to use the hospital for our sickest patients.
Good answer. Neil?
I think the fundamental thing that's going to change for hospitals is going to be, so it's going to be more difficult for maybe for Adam in emergency room physicians, but for certainly lots of the specialist care and specialist hospitals, geography is going to become much less of an issue. So there's always going to be patients that are going to need to come in. There's always going to be some patients that come to outpatients, but an awful lot of the referrals are for an opinion on something. And actually, the more of that you can start to do virtually, it starts to break down those geographic barriers that traditionally, because you lived here, you went to this hospital. Actually, if St. Elsewhere's hospital in Canada is the best place for this, forgetting things about governance and paying, actually, if it's a virtual visit, it makes no difference if I go there or if I go to my local hospital. So I think the whole concept of where patients are seen, where referrals go, and with things like digital imaging, digital pathology, etc., it's fundamentally changing the limits of geography. And I think that will make a big difference globally, actually.
Nice. Karen?
Yeah, and I think finally, I agree with everything Adam and Neil said, but I think the other point is, I think the word hospital is going to continue to mean what it means today. So for example, in a rural community that's a rural hospital today, heretofore, we've tried to make them look like urban acute care hospitals and have failed miserably, because for a whole host of reasons, rural hospitals do not have the resources, they don't have the specialists, they don't have what's really required for acute care today. However, rural hospitals can transform into a different type of healthcare delivery service, just as Neil said, because they can do digital work that can offer some level of care within that rural community. But the role of the rural community hospital may be more on being that more front-facing on meeting community needs, as opposed to high-tech, ever-changing, high specialty care. But there's still things we could do digitally to connect with that high-tech, high acuity care in rural communities because of digital. So I think a hospital is a hospital. We all think about it as you go into the patient's room, they have their surgery, they come back. I think we'll be asking 10 years from now, what type of prototype is the hospital when we hear of a hospital. We could have some hospitals that are 100% digital, and it's not that far-fetched that you're having a fully digitalized hospital in that providers are remote. I mean, that sounds like Star Wars now, but we could really get there. And I think in our image in our mind, the hospitals look like the one behind me, look like the one that Neil is sitting. And I think that's definitely going to change over time.
Awesome. Well, we're coming up against time. I thank you all for your very thoughtful answers, and there's a lot to look forward to and a lot of good change on the horizon. So I wish you all well, and I look forward to this next chapter. Thank you.
Thank you so much. Thanks, Adam. Thanks, Neil.
Thank you.
Thanks so much to all of the panelists, and thank you to Sarah for obviously moderating a great discussion. 45 minutes is always too short for these panels, but I hope at least that's given you a taste of the topic, and I do encourage you to reach out to all of the speakers today to find out more in what is a really fascinating subject. One more session to go before we end for the day, which we have a panel around redesigning and redefining diagnostics with AI and data. So I will see you back here in about 15 minutes, but until then, that's it from me.